Okay, let's go. This is Sir David Hawksby Cox. Uh, does anyone have the experience to sleep during a presentation or a seminar, or also when you are the first on the file and you sleep? This is Sir David Cox. He is a very famous scientist, and sometimes he has this problem, but when he wake up, he do many questions and good questions. He's a famous scientist, and his work influenced a lot of other researchers, and also infrared and thermography breast screening research, as I will show you. He's a sir because he has have a honor from Elizabeth Queen. So he has a medal, so he's a sir because of his contributions to the science. And he is one of the most cited papers in scientific world. It's almost, or it's much more than 62,000 citations of these works here, regression models and life tables. And it has his name, it means Cox regression test. And Cox regression has a lot of influence in breast screening and sure in thermography or infrared imaging breast screening, because this test is open the doors for to understand the evolution and the prediction of any kind of cancer, especially breast cancer. So Sir Cox has a lot of importance on this. Everybody knows, or most of the time, we have occurring bias. Occurring bias happens when we rely too much on the first piece of information we get, the anchor, when making decisions. One of example of this is when we have a normal breast mammography. So when we have a normal, look like that, oh, everything's okay, don't worry, you can have your normal life, and let's see you on the next year. So it's really true that we can rely on this. And then it's really true that we can stay, oh, no problem with a normal exam. So anchoring bias. Mammography is increasing this situation. And if you look for the numbers of cancer, and if you see the 5 last years or the 10 last years, you see only increasing the number of cancer independently of mammographies or breast cancer campaigns. Or so the history, the natural history is not changing, although the advancements on diagnosis, screening, or the guidelines. And here we have a question: how much the occurring bias could be a problem on this? For we to understand and make connection with Cox and occurring bias, we must to answer this question: what is the time zero for breast cancer? If you understand the time zero, you understand the survival outcomes. And survival outcomes could be not only related with death, but could be with chemotherapy, to start a chemotherapy, or to do the first biopsy, or to do a mastectomy. So time zero in survival analysis. The definition is the starting point to measure time into an event. So the definitive diagnosis or the biopsy confirming that it's a cancer or death caused by breast cancer. The example is the diagnosis date. So when a tumor, a breast tumor starts, uh, uh, this is a picture that gives us a general idea of many of breast cancer. Not all of them are this way, but most of them are has this happens in this situation. So when you made your first palpation of a breast cancer, something so little as a bean or a rice and maybe sometimes a little grape, uh, most of the time the natural history of this cancer began 8, 9, 12 years ago, most of the time, not of them, most of them. So there's a phase here that is possible to identify these tumors that are not palpable. And we do this especially by mammography, but it's possible with ultrasound, MRI, and other exams. But there's a very early phase that the tumor not appear on mammography or ultrasound or no anatomic exams, but it changes the circulation of the breast and increases the metabolic rate there. And it's only possible to detect actually by infrared image. So 7 years, 8 years before the first palpation. So it's common, this kind of breast cancers. They are not the so aggressive ones, but is the 80, 90% of them is this way. So the time zero is very important in thermography, in infrared image. Infrared image can track the metabolic patterns over time to assess the breast cancer risks. So here in this phase, we don't have the diagnosis because here it's not possible to do biopsy. So you don't have anything or a specific point that you can really have sure that it's possible to biopsy and confirm it's a cancer. But in this phase, very early phase, is the risk phase of cancer. And if we be following the patients here, and we have patients, and we monitor them, try them to come back and review, we'll find these tumors in 1/3 of the cases by mammography or ultrasonography here very early, very early. So it's not possible to confirm that we can revert cancer. Nobody proved it yet, but maybe in future it will be possible. But we can prove that it's possible to identify very early the tumor here. So no problem. Okay, it's a tumor, but we can identify very early. And if you identify very early, you can change it, the mortality, we can change the morbidity. Most of the case will not be necessary to do chemotherapy, for example, not to do breast resection, total mastectomy. Most of the case will be solved with more simple and more cheap way. So it's very important to help public the early identification here. But most of the women are not identified here very early. Most of them are here between the almost palpable or palpable and confirmed by mammography. So in a not so early stage. Uh, and this is the problem, especially on the third world. So this is why in South America, India, some places in Western world, uh, it's very interesting to have infrared imaging for screening in the early phase because it permits reduce the costs. So uh, establishing the correct time zero ensures accurate survival and event analysis. So mammography not means the zero time. This is what I want to explain everyone. So with infrared imaging, we are much more close to the zero time. The zero time is something maybe in a molecular, orthomolecular or molecular levels. So it's very difficult to say, oh, start. But with infrared imaging, we are much more close to the zero time than the any kind of anatomic exam. This is the point. And this was observed and proved by the Cox regression. Time zero, the consistency in tracking patients. This is the point. Align timing zero across participants to avoid bias. So during the process of early detection, we have many bias here. What are the bias? Some patients don't follow every year. Some equipments have different resolution, techniques, and depends the place. The woman not really do exactly year by year. So every October, every November, it's not the reality of many women in the world. Uh, Consistency in track patients facilitates comparisons of outcomes, especially with repeated thermographic infrared exams. Because, as you know, most women don't like so much mammography because it's not comfortable exam, although it's very important, although it's the first line, although it's the most recommendable, but some women have difficult uh, to do these exams, especially if them have big breasts or very little ones. And with infrared, you don't have this problem for tracking the woman because it's just a picture, no contact, no radiation, no pain. So it's you can repeat if you want 3 times, 4 times per year in every medical consultation with her gynecologist if she wants. And what we see on breast infrared image, we will see not it's not the temperature on, it's the metabolic rate and especially the morphology of the vascular pattern. So if you're following time by time, you can see an increasing in the circulation of a specific area. And maybe this could be a tumor. If you repeat the exam time by time, and you see these changes growing, spreading, increasing the metabolic rate, wow, the chance to be a tumor is much high, is much high. So we have here alarm. We not have here a specific diagnosis of cancer. We have alarm, like a clock, like your cell phone in the morning say, bang, 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 bang. So you must do something. This is the point. Uh, Time zero, impact of incorrect time zero, biased conclusions in survival analysis. So if you have, as I told, normal mammography, you are creating a biased conclusion. If for example, in 1 or 2 or 3 years, that woman will be diagnosed by cancer. So you have a normal mammography in 1 year, in the second, but in the third you have tumor. So it's must probably you made a biased conclusion when you told to that woman that everything was normal, was okay. So it's not good. But when you have a positive, suspicious thermography, you have alarm. And alarm means that, oh, take care. Okay, your mammography is normal, but you must do something. You must to avoid, uh, you must to take care of your weight. You must to stop smoking, change your diet, start to do exercise, or there are many supplementations to help on this or to decrease the chance of the natural history of cancer. It's possible. And, and this is what direction we must to go and not just wait for the cancer. We cannot wait, sit on the train hail, and wait the train pass over us. We must to wake up and change, change and sit in another place. So overestimation or especially underestimation of cancer progression risks is a biased conclusion we must to take care with more. So this can explain why the number of breast cancers are increasing independent of the exams? Maybe yes. So here's a sequence again of something wrong is happening on this breast. The first image, after time, 2 months or 3 months, 6 months, 8, 9, 10, 1 year. So 1 year, sure, there's something very different on the breast, and this is an alarm. Why Cox model is valuable? Because it adjusts the risk analysis based on metabolic patterns and other variables. You can mix the temperature, the age, the natural history, familiar history of cancer. You can put other variables and adjust the risk analysis for tumor. And also, the B-Radson mammography can put here on this model. It evaluates thermography's role in improving early detection and survival outcomes because we don't have a fight or you cannot do fight between mammography and thermography, for example. There's no sense. We must join the technologies and especially join the clinical evaluation, the data of these patients to improving the early detection. So Cox model is a proof that if you adjust many variables, not only mammography, not only thermography, but age, history, family, we can improving the early detection and survival outcomes. Here's an example of survival data. It's just an example. Imagine that we have here 8 patients. Each of them are screening in different moments. And for example, if you're screening with mammography, you can have someone being screening by the time and that in a moment she stopped to go to mammography. So it's a problem. Here is another situation. And we start to screening. And by a long time, she found a tumor. Okay, this is another patient, found the tumor very early. This one started with more age, more older, and stopped to fall on. So we have different situations when you use only one method of screening. So uh, all of these things can help when you use only mammography. But when you stimulate the patients to use both exams, or maybe a third exams like ultrasound together in this, you not uh, censor patients, not lose patients on this process, because you can increase the data. The breast cancer screen, uncertainty in risk progression is something always present in any kind of exam. So we cannot say that mammography is better than thermography, then is better than ultrasonography. No, each exam has its own importance. If we do all of them, if possible, you increase the certainty in risk progression. But let's see the numbers. 20–30% of patients may have early stage abnormalities not visible in mammograms. So mammograms has the sensitivity between 70–80%. So in 10 women that do mammography, 2 of them has cancer, but is not detectable. So take care of this. 30% of infrared imaging, grade 3, that is indeterminate, so very suspicious, but is in the middle of classification between 0 and 5. Progress to cancer within 2 years. We have papers about this, papers in the 80s and the 90s with Galtieri, and actually papers using artificial intelligence and showing the same numbers, that when you have a suspicious infrared image, at least 1/3 of these suspicion images can progress to cancer within 2 years. Some papers show it 5, 8, into 10 years after this, okay? But most of them is 2 years. Thermography, urothermography reducing sensory. Sensory is when the patient stops to go to the screening. Thermography detects metabolic and vascular changes before structural changes are visible on mammograms. Okay, we told about this. Without thermography, clinical observations may be incomplete, leading to undetected risks. Okay? Let's see. Again, to understand, so the S marks the start of observation. The time 0 of observation. The O is the censored observation. So the event did not occur and monitoring stops here on 0. It's happened very common with mammography. X, the event occurred. Cancer detect, okay? So thermography helps reduce sensory observations by identifying risks early. Why? Because it's a clinical complementation of the evaluation, and it's easy, fast, instantaneously imaging of the patient. This is the point. We must remember some points here. Is it possible to prevent breast cancer? Can I say this? Let's do infrared because it's possible to prevent breast cancer. Until today, we cannot promise this yet. We expected this, we tried this, we are working, we're studying this, but we must take care because it's not something that we can really prove. If someone prove, I'm open here to learn more about it, to know how you prove it, how you did it. Okay? But we are want to go into this direction. Thermography does not diagnose breast cancer. You must take care when you say this on the internet or where website. So the FDA explained this very well. So FDA is not forbidding the use of thermography, but forbidding that we say that we diagnose breast cancer or that we use it alone. Why we cannot use alone? Because for the diagnosis of breast cancer, we need biopsy. We need to see the cells and confirm on the microscope that are cancer. And for to do this, we need to anatomical exam. The most common used is mammography. So in mammography, you direct a needle, do the biopsy. Most of time, when possible, when you have a good specialist, you can do the same with ultrasound. So, but with infrared image, you cannot, or is not recommended that you do biopsy guided by infrared image because it's a functional, it's a metabolic, it's not the anatomical. So you have a big area of increasing heat with a little or deep tumor, okay? So it's not possible. But thermography helps in the diagnosis of breast cancer because thermography is a biomarker of the risk. It's a biomarker of right metabolic rate and that it's related to breast cancer. So take care with the words when you put in the internet and not explain better about this. Infrared biomarker is not isolated screen. Why? Because we need to see the tumor in one moment. When? If you only use infrared image, we don't know when we do the biopsy to confirm when necessary. Most of biopsies are normal, are benign tumors, not normal, but benign, okay. This is a problem we can discuss in another moment, but it's necessary. But infrared is not a diagnostic test alone and is not substitute for traditional exams. So take care of it. So we're not in a fight. We are trying to elevate the quality of cancer screening. Types of sensory in breast cancer screening. You can classify the sensory in right, left, or interval. The right sensory, cancer has not appeared yet. For example, mammogram is normal, but monitoring ends. So this is a big problem in all countries. Left sensory, cancer may have developed before studying tracking started, but exact time isn't known. Yes. So if you put thermography here, you will be much more close to the 0 time. Interval sensory event occurs between two screen exams, but the exact moment is not recorded. This is an interesting situation. It's common, for example, most of women have a normal mammogram, and 1 year after, wow, the tumor is there, 1 centimeter, aggressive. How is possible in 1 year? The answer is that maybe it's not a period between 1 year. Maybe could be a period early of this is a possibility, a high possibility, and we can prove this specifically in the case if we had infrared image before mammogram. So, uh, why thermography helps manage sensory? Why? Detects early metabolic changes that indicate abnormality before structural changes are visible. Reduce right censoring by monitoring high-risk individuals even before cancer appears on mammograms. So this is very important, but it not means that it's a breast cancer diagnosis, but it's very important to reduce right censoring, okay? Let's study about this, and we can contribute much more with infrared imaging in breast screening. Provides more data points for survival analysis, improving predictions through more complete observations. You can understand the location of the suspicion, you can understand the progress, you can understand the response of some habits or some nutritional supplements, or you can study these things. You can go to direction of prevent cancer. You can study better this. Actually, is much more difficult to study the, uh, the treatments or the therapies to revert this without infrared imaging. So if you use infrared imaging, we are going to direction in near future to reduce the change or revert this. It's possible, and let's go to do this. This is a Kaplan-Meier estimation. Here could be his pain, but could be breast, for example, breast cancer. So maybe you can reduce this by the time in the near future. We have many different statistical methods to hand sensor data. We have a Kaplan-Meier estimator. It's a best from the 50s, very old, and it's used until today to estimate survival probabilities using sensored and sensored data. The Cox, Professor Cox proportional hazards model analyze the effect of multiple variables. This is our case, even with sensored observation using partial likelihood. Life table analysis useful for grouping data into intervals and managing large data sets. So the next papers with infrared imaging must be using one of these models to predict. It's much more important to only identify and trying to say, oh, it's cancer, not cancer. No, we must study the prediction using these statistical models. So this is my suggestions for the next papers with breast infrared imaging. The impact of cancer risk assessment. Ignoring sensory can lead to underestimating or overestimating cancer risks. Accurate survival analysis allows clinicians to track changes more effectively and intervene earlier. Thermography ensures consistent data collection. It's very important on this process of data collection, which helps identify risks at different stages of observation, and especially to show to women that we have alarm here, you must return, and our exam is complementary to medical evaluation, no pain, no radiation, and you can see and understand on image that something is wrong on your breast. When using a Kaplan-Meier estimation, we use the median survival. Median survival helps in assessing how long it takes for a cancer risk to materialize in high-risk patients. The mean survival may be less effective due to incomplete observations, especially with sensory data from thermography. So we are almost close of this, to have the images, to calculate the median survival and estimate in high-risk patients when the cancer will appear So I told you, actually can say maybe in 2 years, 5 or 10, but in near future, it can be more precise with this information. In near future, you have grade 3, 4, or 5 in breast imaging. And even with a normal mammogram, you can say, wait, because here in our Kaplan-Meier or Cox regression, we can estimate the risk in 2 years in your case. Take care. So it's not to be worried or kill themselves, but we can do a lot of things during this time, and we'll be waiting for that moment. In that moment, when we discover the cancer, okay, let's do what we have to do. Now we can do the biopsy, confirm, and do the treatment without chemotherapy, without mastectomy. So we are almost close there. The hazard ratio, HR, it represents the relative risk of the event occurring at any time point for individuals with different values of predictor variables. This is what I'm saying. The hazard ratio based on infrared image. If the hazard ratio is more than 1, means higher event risk. Hazard rating less than 1, lower event risk, and equals 1, no impact of the predictor on event risk. For example, a high thermal asymmetry may yield HR more than 1, indicating a higher cancer risk. Does make sense? Sure. Let's speak now to them. Comparing survival distributions. We can compare in the future different kinds of preventions ways. For example, maybe if I use a specific type of prevention, nutritional prevention, we can extend the time to find this tumor and compare with the women that don't do nutritional prevention, for example. So it's not full preventive, but you can in the future say, oh, if you don't do this kind of supplementation, you will identify more early the cancer. If you do this kind of supplementation, you can decrease the chance, or maybe you die with other problem, heart diseases, older, and never you have cancer in your body, okay? Specifically, I'm saying breast. This is the paper of Galtieri in the past, where he put in histogram graphs the chance of having tumor after grade 3, after grade 3. So he do the thermography in 784 cases, and he found cancer, most of them in between the first and second year. So here in the second year is where the cancer is appearing after treatment 5, abnormal thermography and normal mammogram. And repeating the mammogram, he never said he was a guy's mammogram. He always used Galtieri, always used mammogram. He found in most of the case, in 2 years, they find most of the tumors. But he found 3rd, 4th, 5th, 6th, 8 years, 9, 10 years after the first infrared asymmetric image. It's amazing. Some years ago, is one of the best papers about this. He was following the patients, and with grade 3, here he has 1,525 grade 3 tumors. Some of them was carcinomas, most of one of benign, and most of them are normal. And when he put this, we followed this normal on mammogram, but grade 3 on thermography, he saw that in 2 years, half of them become normal, and a part of them confirmed cancer. 22 progressed to cancer in 2 years. And he followed these 496 patients, yet normal, on mammogram, and 5 years later, 15% of them was confirmed cancer. So thermography is very important as a biomarker. What is the time zero for breast cancer? Again, we don't know the onset. The exact beginning of cancer development is difficult to determine. But thermography has a specific role. Alerts patients early, much more early than mammography. Mammography is the last word to say, now we have a cancer. Thermography is alert, maybe, until we find this. Alerts patient early signaling when closer monitoring or treatment should begin. Closer monitoring. Treatment here means some lifestyle modification. Positive impact of thermography alerts. So thermography alerts is a reminder system. We must if you will evaluate breast, you must create a reminder system. Reminder system acts as a reminder to seek proactive care when risk factors are detected. When you have a normal mammogram, the woman is not proactive. It's normal. You don't need to do anything. But when you have alarm in breast, the woman must be proactive with her diet, exercise, stop smoking, eat correctly. So we can change the natural history. It's possible. Thermography alerts is timely interventions, promotes early treatment, early proactive lifestyles changing, improving outcomes by detecting risks before structural changes appear. And if the woman is more younger, it's more easy for her to do exercise, for example. She has more financial conditions most of the time. If the woman is more older, it will be more difficult to start exercise, change the diet. The motivations maybe could be different. Not all the case, but most of it. But we have some challenges on these alert systems. We must take care with alert fatigue. Take care. Too many alerts can overwhelm providers or also the patients, leading to ignore the recommendation. All the times he's saying, it's not good, it's not good, it's not, I don't know, I don't want to go there again. So take care, because we cannot create a big alarm with this, but we must to say, I'm here to keep you safe, and I'm here to help you on health. So the professional that like to work with breast thermography, he must like to work with health. Because we're not talking about treatment. The treatment is the last stage. If we're the surgeon, oncology, here we're saying we identify some kind of risk, we have alert, and we must choose give help to this woman. The relevance matters. Specific and well-timed alerts are crucial for maintaining attention and compliance. So almost All the reports must have some kind of recommendation to return. 3 months, 4 months, 6 months, 8 or 1 year, depends of the grade of alert. The best practice for effective alerts, customization. Alerts should be tailored to each patient's clinical profile to avoid unnecessary notifications. So we must balance this. Integration is very important, actually. Seamless integration with EHR systems increases the likelihood of compliance. What is HIR? The electronic alerts, the cell phone alerts, the emails alerts, any kind of electronic alerts is very important, actually. Not just the report, the paper. We must call to patient, we must but call, inviting to a health, inviting her to a consciousness about possible problem. If the cancer don't become true, oh, great. Instead, no mind if you change your lifestyle, but you did something good for your health that could influence other organs and other problems as heart problems, for example. Continuous evaluation. Ongoing feedback loops help refine alerts, ensuring they remain effective and relevant. Comparing survival distributions. Faster diagnosis with thermography. Thermography detects solid tumors 3-5 years early than mammography. Not specific tumors, but the risk of tumors. Identifies vascular and metabolic changes before structural anomalies become visible on image. The risk of interval cancer. Interval cancer is when cancer is diagnosed between scheduled mammograms, often more aggressive to missed early detection. So with infrared imaging, we will not have most of kinds surprise. I don't have, it's normal and now is the abnormal hotspot. No, with infrared imaging, we are preparing the mind, we are preparing the body of this woman. Skipping a mammogram, very common to happen this. Missing just 1 year of screening can significantly impact treatment outcomes and increase the morbidity and mortality. So imagine if a woman missing just 1 year of mammogram screening. Wow, could be very radical. And the things can change a lot of things. And it's very common to this. The benefit of combine thermography and mammography. There, sure, we must think about this. Thermography complements mammography all the time, ever, by identifying high-risk case early, and also help the radiologists to looking that breast, the left, not the right, the upper quadrant, not the inferior. So it alerts also the radiologists to look again, to see again, to repeat, or to reevaluate the missing findings on mammography. So this point of view is also important to them. Reduce the chance of delayed diagnosis and improves patient outcomes through early intervention. Early detection with thermography, critical time advantage, improving programs. Using both methods ensures more comprehensive breast cancer screening and reduce interval cancers. My experience is infrared with mammogram, with ultrasound, with elastography in some situations. So more is better in this case. Thank you so much and welcome for the next medical minutes. And now we will open for the questions. Thank you. Hello, Robert King. My friends, how are you, man? Look like Scott there.
There we go. There we go. How are you?
Fine. Fine. Did you understand what I told you, or is a little complicated, many details? I would like to listen your experience, Kane. You one of here. Here you one of the who has much more experience between us.
Yeah, I came in about halfway through the presentation. I just misunderstood the time. But from what I see, I appreciate the clarification of the role of thermography versus using it as an enhancement of radiology rather than a replacement. My experience, over the last 30 years has been the women that try to use this as a replacement for a mammogram miss cancers. They just miss them because the thermogram doesn't pick up everything. And at the same time, if it does pick up something, they think everything can be changed with nutrition, diet, and lifestyle. And while risk assessment and management is certainly very important, we have to recognize that some of these are frank cancers and they are beyond that stage of being able to do preventative intervention. So the application of using it with radiology to me makes the most sense because, as you said, when we have this biomarker, we now have a signal as to when to begin radiology. So certain women might need to begin radiology early based upon their specific risk marker, just like a woman with a BRCA gene would they might begin screening earlier than age 40 because of their genetic predisposition. So thermography potentially could be used that way as well, determining who needs earlier screening than the general population. And then the other piece is who needs more enhanced screening, not just a yearly mammogram, but additional screening with, let's say, ultrasound or MRI. We know that in the high risk population, again with BRCA genes, many doctors are actually augmenting their screening using MRI because either the breast density is getting in the way, or they just want additional information because of the additional risk. So thermography could be used to place this in the same kind of category. We determine who the high risk population is, and then we modify screening appropriately. Now, I can tell you personally, there's been so many studies where somebody comes in, we have a thermal marker, it's maybe at a Th4 or Th5 level, and that person basically gets their screening mammogram and their screening mammogram is normal. But with the knowledge of the thermal findings, they're encouraged to get something more, whether it's an ultrasound or an MRI. And lo and behold, that's where we find the cancer. So these are women who would have been undiagnosed because the mammogram was normal, but the risk signaled by the thermogram encouraged additional testing above and beyond. And that's what we're looking for from, to use Peter Attia's terminology, a medicine 3.0 perspective, where we're looking at how can we use better screening to catch things earlier and how we can identify biomarkers so that any preventative actions that are appropriate can be implemented at the earliest possible time. Now, I know for many years we've recommended thermography start at age 30. And that might seem silly. Why? How many cancers do you think you're going to find at age 30? And probably not many. But if we do detect those biomarkers, we might be able to intervene with lifestyle, diet, risk reduction strategies, and lower the effective risk going forward. So by the time they start screening at 40, their effective risk could be lower. So I think you brilliantly covered a lot of what I would consider in my career the biggest applications of using thermography in the breast cancer practice, enhanced detection, and possibility of lowering risk and maybe even preventing some of these things. Of course, we need more research to establish this, but the potential is certainly there. And I think that's where research and clinical practice needs to be focusing.
Uh-huh. I would like to listen the commentaries of James Campbell. James Campbell is
Yeah.
also a scientist. He has some papers published, and the last one I have the chance to review his paper is amazing paper about the reviewing and the importance of the temperature of nipples. Please, James, explain to us and comment about. Welcome and thank you.
Well, thank you. This is once again a surprise meeting. I woke up to 9 o'clock meeting. My wife did bring me a cup of coffee, so I'm maintaining. Welcome to my laboratory, my biomedical engineering laboratory. Um, as for a couple of, I want to before I jump into nipple temperatures. Um, a couple of comments on your presentation, Marcos. Um, you remarked that a lot of women don't like mammography because it's painful, and this is a very important and often overlooked uh, problem with testing that doctors. It doesn't hurt the doctor; it hurts the patient. So the doctor's not particularly aware of it, unless the patient really complains or just says, "I'm not going to do it." Um, we have to take the same approach with thermography. And thermography is not painless. Cold is, you have to be cooled down, and that is a type of pain, and certain people don't like it. So we have to minimize that, and especially that's why uh, I do not encourage cooling, like water cooling of hands or whatever during breast thermography. It doesn't seem to show anymore, and it turns people off and say, well, I'm not going to come back for screening. That said, uh, uh, we're definitely better than mammography for on the pain scale. Um, the other thing is uh, follow up. Any recommendations for follow up frequency? Right now, if a person has a normal TH1, TH2, I say 1 year, come back in 1 year. Uh, 4 to 6 months if TH3. And then this is it 4 months? Should we do 6 months? If it's equivocal, should the person come back sooner or later? And definitely uh, referral for other imaging if TH4 or 5. Presently, I'm working with a clinic that I'll just say it services high-end clientele. In other words, they're not worried about money. And we have decided to basically, if a person is TH4 or 5, they just skip mammograms, go directly to breast MRI. They can afford it, get it. Their insurance probably won't cover it. Fine, they're going to get it anyway. But this is not available for everybody, and a lot of people can't afford it. But it's something we do, and hopefully we'll get some good data on this. Uh, but to uh, go to nipple temperatures. Uh, Nipple temperatures were not really available to thermographers before the advent of the modern microbolometer imager that we have today. The old scanners simply were not didn't have the spatial or thermal resolution to locate the nipple. If you can't locate it, you can't measure it. So that said, um, I used my data set over 7 years to examine nipple temperatures versus breast temperatures. And as for picking up, nipple temperatures look like they are a good signal for early or progressive DCIS. This is an important flag. Um, One must also take into account the possibility of duct infection, which is not good either. But exactly how do you detect that if it's an indolent infection of the nipple? Your mammography and breast MRI is probably going to be normal. Maybe a discharge that you can pick up. to pick up
Okay,
pus.
James.
Yeah.
Because we have a
Anyway,
reduced time.
yeah. Go
Uh,
ahead. Go ahead.
but let's
Thank you. Thank you
I
for this
want to
meeting.
join all the info and comments at the end here. Please, Jen, you can speak now. Jen is here, but could you please
Yes, I'm
open?
here.
Oh, thank you. Here's Jen Crawford. She was one of our past presidents of American Academy of Thermology. She has a lot of experience also with breast thermography. I mean, maybe it's the one of the most exam that you have done, Jen. Is it true? Comment about
Yes.
your
Um,
experience with us.
I've been fortunate to practice now for 23 years and was working under Dr. William Hobbins till he um, until he left this go round. He's hopefully going to make another go round and push thermography even more. One of the things that I've found is definitely the risk factor. I think that because medicine has pooed this as a risk indicator, it's made it more challenging. You need an assertive woman to be able to go into her practitioner and say, you know, I don't really care that you don't believe in thermography, but you can watch the progression of my thermograms. And I think that we need to follow up in a different way. Currently, we are very fortunate that we have new blood tests that have come online that can be offered to the patient to detect early cancers. So when I have a patient whose physician is not in favor of their thermogram, I tell them that they have the option to go ahead and have their blood tested for early indicators of cancer, because that empowers them more than continuing to be put off by their doctor for other investigation. Most patients with high-risk thermograms ask for Doppler ultrasound. You need Doppler to be able to follow the blood flow that thermography indicates. That Doppler can compare the region of high risk blood flow in a thermogram to whether or not that blood flow appears normal on a Doppler. And that also helps the patient have a better understanding of that risk indicator.
Great.
So hopefully more physicians will join in some of these options.
Okay, great. Before I open to the questions, I want to remind everybody here that in October 19, we have an amazing meeting that will be half a day on Saturday, and with where we will speaking again about the breast, and here with some professors that have a lot of experience. Many of them are here on this room. Sidalia is here, and Rita, Sergio, Professor Sergio. Most of them will be with us, explain new things. It's showing infrared image is a game changing in the medical field to help people in the health and public health. So don't forget October 19. The ones that is member is a red member. It's totally free for the active members. But if you're not yet a member, why not become a member? Come with us. But if you don't feel that's not the time, okay, we have a special price. Stephanie is until Monday, yeah? Until Monday is a special price of
That's
$49.
correct. Yep.
So
Yep.
for amazing.
Our early bird
meeting.
ends
So
on Monday. So it's just
all
$49
this
right
money
now.
is for the American Academy Thermology to help the administration, the memberships, is all reverted for the association. It's not for the professors, okay? But let's to end this meeting of today. I will open, if you have any question, if you here have any question, please, this is a good chance because we have many experienced thermologists here that can help to answer your question. We have here Albert Kane, James Campbell, Jen Crawford, that have a lot of experience. Does anyone have any questions?
Let me jump in here and ask Jan, what early indicators are you ordering for this?
Well, because I'm not a physician, I do not order anything. I usually will talk to the patient's physician if they're interested, but I encourage the patient to be more assertive with their feelings about these problems. And again, the new Gallery test allows the patient to test their blood independently. They can get that test through their practitioner. There are many practitioners who will order the kit for them. They pay the laboratory. They don't pay their doctor. They get the test results. And it can give them at least an assurance that there's no early tumor cells that are being identified. But I cannot order tests. I can only suggest.
Well, the Gallery test, is that what, I'm sorry, we are doing testing in the clinic that I'm working with, and they rarely are positive, but occasionally they are. Occasionally they are. Yes.
Okay. So October 19, we'll be talking about breast thermography and hormone replacement. And Professor Rita will show her experience on this topic. So it will be very interesting you to see breast thermography, not only with the point of view of cancer, but the hormone replacement. Sure, cancer is involved on this, but the women on that month are worried with hormone replacement. So don't forget the next October 9th. We are open for suggestions. If you want to send your suggestions for the next Saturday's meeting, or if you want to present something very interesting.
Eu tô olhando para a tela, eu tô olhando para o papel, olha lá papel.
This is the place. Okay, welcome. Send the email for me or for Stephanie if you want to take part or to do your presentation or send your suggestions. And also for the we have people here from outside of US. Here we have Irma. Irma is from Netherlands. She's we can promote if you want, Irma. But to explain that the American Academy is open is open for other countries to be members if you want. Okay, it's not specifically for US. We have members from Canada, we're from South American, European, and we are open to this. You want to say something, Stephanie? Sorry.
I just wanted to, this was a really timely comment or presentation. I wanted to share, I'm actually one of the women you guys are all talking about. I had to go get a mammogram yesterday. So just weird timing. And I obviously know about it. I've had one before, but I do have some other health issues. And walking in, I got so anxious. I got so nervous that my entire face turned red. I walked in and they were like, "Are you okay? This is really normal." And so I was talking to the lady about it. And I said, "Do a lot of people come in here really nervous?" And she said, "Yeah, they do. They come in really nervous. We spend a lot of time just calming them down." And then I actually asked her about if she knew anything about thermology and infrared imaging. And she was really surprised that I knew about it. And she was like, "Oh, yeah, actually, that's something that I wish more people knew about." So I just wanted to kind of like as a normal everyday person, because obviously I'm not in the medical field, really reiterate what you guys are talking about. I think there's so much anxiety and fear for women, and it is 100% not comfortable. It's not a fun test to get done. And I've had obviously thermography, but I think also the fact that there was a nurse in there who was like, "Oh, I wish more people knew about it." So there is, there are people in the industry, in this field that want to learn more. But the question is how do we get to them? How do we target them? What kind of information do we give them that really helps them to understand that this is a complementary test and diagnostic tool that helps them as well, because their entire goal is for people not to have breast cancer. So I know we may not be able to, we obviously can't answer that today, but something I think for everybody to be thinking about, and that I think something that AAT would really like to target is, in general, how do we get out more information? Because honestly, as you guys in the medical field, you're really tough to target. You don't do a lot of social media. You're not checking, most of you don't look at your own emails in your offices. Somebody else might be checking them. You're getting thousands of brochures. So what would it take to actually help you to understand that this could be a really positive tool for your patients and for yourself? Those are the things that we're trying to figure out.
Thank you so much, Stephanie. And remember, if you have the pleasure, the opportunity to find something wrong in a breast thermography, some kind of alert, and if just find will confirm in the future as cancer, well, you will do amazing thing to this person, because it could be one case, but it would be the case you never forget on your life, that you saved a life. So don't forget this. And if we have this opportunity, you can absolutely not be feel bad with someone say, oh, thermography is not working. Oh man, when you have many cases like that, you know you are in the right way. But sure, we can do better. Okay? Let's take on this direction and make better for everyone. Thanks so much, and good meeting for everyone.
Thank you, Marcos. Great meeting.
Thank you.
Yeah, looking forward to the other meeting coming up.
Congratulations, Marcos.
Wow, who talk? Gabriel, thank you. Gabriel is from Albert, Sarah, who's the name? Sorry, Sarah.
Rede Sara de Belo Horizonte.
Yes, it's a rehabilitation center on Belo Horizonte.